Thank you so much for attending the breakout sessions, especially the last one. I was worried that we might not have significant numbers, but I'm happy to report that all the breakout sessions had
recording in
numbers.
Progress.
So today is a really great day. We are bringing this event to a close. So we want to land this plane with a bang. So what are we talking about? Today we have one plenary session, mobilizing the public and building. Dr. Bernard Mwinzi works for the Nation Media Group. I also want to remind you that after tea, again, we're going to have a breakout session, which is going to be quite short. It's going to be from 11 to 12:30. So you need to pick your tea quickly and go to the breakout place. We have 5 tracks. Once again, if you go, I haven't yet been given the guidance. But I want to tell you that today, the director, Bernard Mwinzi, to come. I hired another name. Yes, yeah. Karibu sana. So Bernard is going to take over and he's going to introduce his questions. So if you have any question, please write it down so that at the opportune time, you will ask the question to whoever it is you want to ask. We will also be welcoming questions from our online community, and we welcome them on board as well. I know you're online, so you're not feeling the cold of Runda, but we welcome you, and at the opportune time, we'll also take questions from the online community. Karibu Bernard.
Good morning. How are you this tea? So I suspect that you're fine. My name is Bernard Mwinzi. I'm managing editor of the Daily Nation and also the editor of Health and Science at the Nation Media Group. I'm happy to be here and happy to engage with you this morning and lead this conversation. As explained, this session will be about mobilizing the public and building alliances for sustainable blood and organ donations in Kenya. And I think it's important that we have that conversation now because it's taken us so long to start having debates about organ donation, blood donation, and all that. We still haven't developed a culture. We still haven't developed the right policies and the right postures as a nation, as a community to start doing that. This, therefore, is very, very important for us to start moving the conversations at the community level. I will call my panelists one by one. Dr. Githinji is joining us online. Githinji is works for AMREF Health Africa and will be talking about mobilizing the
I can hear you clearly, Bernard. I hope you can see me.
Yes, we can. Yes, we can see you now. We can hear you and we can see you. I'm also joined by Angela Langat, who is the Deputy Director for HIV Investment at the National AIDS Control Council. Angela, please. For this conversation as well, we are joined by Mr. Philip Ogola, who is a digital humanitarian, and he will be talking about the power of social media in mobilizing and educating donors. Karibu, Ogola. And also, we are joined by a lady who wears 2 hats. Ms. Leah Kilenga is the founder and CEO of Africa Sickle Cell Organization and also a person living with sickle cell. Karibu sana. She will be talking to us about leveraging communities of blood recipients for sustainable donation. In the interest of time and so that we move quickly, I would like to ask Dr. Githinji to make his presentation as we move forward. And then if you have questions, please park them. At the end of his presentation, we'll ask, he's logging off in a few minutes. So I suggest that we park the questions. Immediately he stops, he finishes his presentation, we get into Q&A with him. Dr. Githinji.
Thank you, Bernard, and thank you, colleagues. I wished I would have been there in person, but the schedule for the day could not allow. So I'm missing you all. I'm missing seeing you, hugging you, hopefully shaking hands and sanitizing, and just being in the same space. So thank you very much for having me. I want to comment very quickly on the topic of mobilizing the public and building alliances for sustainable blood donations in Kenya. I have deliberately left out organs donations in my talk because there are probably some here who are more experienced, skilled, and more in the right place to speak about organ donations. I also want to talk a little about regular repeat blood donations as the worthwhile health system goal. So I'll just make a few remarks, then we can have a debate after that. Again, a keynote address is not supposed to be a solution, it's supposed to be trigger conversation, and I'm glad that I'm here with a great panel of experienced individuals in this area. Well, globally and here in Kenya, maintaining an adequate blood supply to serve health system needs of saving lives is an ongoing challenge. So it's not a Kenyan challenge alone. We continue to suffer a very high burden of preventable mortality from inadequate, timely, unsafe blood and blood products needed to save lives. And we know this is a major contributor to our high burden of maternal mortality, probably one of the biggest contributors to that. Well, whereas we must laud the Kenya National Blood Transfusion Services for raising our annual donations from what was around 165,000 to now current 273,000 in 2021, which many of us hope is sustainable, that will continue to do so and continue to increase, that it is not a one-off, and that actually this supply increase also is matched with the demand. We are still far from national target of 450,000. And of course, I would like to argue that considering that Kenya's economy, population continues to grow and our needs continue to grow, I would estimate 500,000 units annually for our population, from our population growth and increasing needs, awareness, and access. Of course, access to health services also increases demand for blood, because in the past there are people who didn't have access to any health service at all, and therefore blood did not come in because they didn't have access to any health services. And we know it's increasing from the UN Global Monitoring Report of 2021. Access to health services is increasing, and with that increasing demand for health commodities. And of course, populations are growing. The question is whether we are able to match that. Yeah? The goal is known, and the gap is visible. How do we actually create sustainable blood donations that meet this gap that we talked about? The question for us, therefore, is how do we mobilize the public and create alliances with the public, with private sector, with communities for sustainable blood donations in Kenya? WHO recommends that the best way to do so is through voluntary, non-remunerated regular donors. However, we know that majority, including ourselves, of the people who give blood are one-time donors. I know that the number of times I have actually got to donate blood is because a friend requested. I had to donate blood for my father at one point. I have had to donate blood for relatives of my friends. But I need to step up to be a regular donor. And why is it that I don't? And when I was in primary school, I was a regular donor because secondary school I was in, because I would always receive the soda half loaf to go and queue and donate. Other than outreach in schools has been the key model of giving, which has proven both inadequate and unreliable for national health system needs. Available literature, which there is a lot of, and not a lot of research I could find here in Kenya, but of course there is research for some countries, sub-Saharan Africa, a lot of it in Ghana, points to various reasons for poor recruitment of regular givers, including culture, convenience, fear and stigma, and low awareness. But the same literature does point out to great opportunities in community responsibility, mostly harnessed by altruism or the need to help others, convenience, influenced by peers and opinion leaders, as well as subliminal messaging and reminders, which is, I'm sure, is going to be talked about here. I therefore want public and building alliances, sustainably financed as well, which will lead to increased regular voluntary communication, which is the first C, must be real to the people, overcoming their fears and challenges, which means that we may need to go where they are, not just craft communication from the center. They must be relevant to them, explaining why this is important and why they should pay attention to it, and why they should actually leave their work or whatever they're doing and do this. And finally, must resonate with the people that this is something that touches me. This is something that resonates with me. It's not something I'm doing for KNBTS. It's not. Secondly, and that communication should use all available platforms. I know that the digital humanitarian is here. So talk about social media role, and I couldn't find out of data where social media has been used successfully, especially in sub-Saharan Africa. So it would be good to hear a little about that. Secondly, convenience and friendliness. In most of the literature I reviewed, friendliness of staff, customer service was critical. I asked my wife and said, if you wanted to donate blood today, where would you go? And she had no clue. She said, I don't know, maybe if I go to the nearby hospital. And I said, those things, is there convenience that people can actually donate conveniently from where they are? So convenience and friendliness is the second apex of the triangle. A human-centered design to blood donation, and innovation. Innovation that connects to the third C is community alliances. Community alliances are critical. Opinion leadership, relevant to communities, proximity to communities, common interest for common goals. So basically I'm saying this triangle of three: communication to overcome stigma and communities. So as I close, I want to say that the most successful approach to recruitment of volunteer blood donors has been an appeal to community responsibility, and has to be done matched up with communication. Repeat donation is convenience and friendliness from most of the literature that I could find. For whatever reason each donor is motivated to give blood, he or she must be convinced that donation will be convenient, is truly necessary, and will be appreciated. And once the donor has been motivated to donate, making his or her blood donation a convenient and pleasant experience is critical to retaining that donor for subsequent donation. And this means that blood incorporating workforce training, incorporating scope and performance, and not only focusing on outreach, but fixed donation centers, which are best implemented with private sector partnerships to make the donation process as pleasant and convenient as possible. If they are successful, a hesitant first-time donor may be converted in the community. Somebody who is to needed services for all.
Regarding what we've been doing, what we are doing right, and most critically, what we are doing wrong. I find it interesting that you're placing communication at the heart of this, that it is important that communities are made aware of the need to develop a culture of donation, and that we must all agree that where we create awareness and we build, as you're calling them, the right alliances, whether institutional, whether infrastructural, whether financing alliances, then we will be moving in the right direction. This initiative has to be funded, that's a fact. I agree with you on that. And also, most importantly, it must be convenient for people to move ahead and donate blood. I also don't know if I wanted to donate blood today, where I'll need to do. There are blood drives that are organized, but I don't think that model. But Daktari, just a quick one, and those of us who are joining us online, to comment on sustainable communication perspective. What do we need to do to develop this culture? We've been at this for a very long time. I was just having a conversation today in the morning as I prepared for this and asking people. We've been talking about blood and organ donation for a long time. Newspapers have written acres and acres of articles regarding the same. Why is it that after all these years of communicating, advocacy and all that, we are still not making much inroads in that space? Daktari, you're on mute.
Thank you, Bernard. I was muted about the effectiveness of communication. I am a communications person as well, Bernard. Maybe you didn't know this. You know, I worked at Nation Media Group actually for many years, and also a newspaper in Uganda. I have been head of marketing and communications, and I know that communication 101 is that communication is understanding. Communication is not dissemination of messaging. Communication happens when the intended recipient understands the message. What we tend to do a lot is to disseminate messaging, not to ensure that the recipient understands the message. In many communities where we expect this to happen, we cannot do it through billboards. Those are important for supplementing subliminal messaging. Face-to-face communication through community structures like community health workers, face-to-face communication through opinion leaders like religious leaders, alliances with the churches, with the faith leaders, alliances with local leaders, so that communication does not only come through the screen in the room, come through the person you trust on a daily basis. And finally, in some areas, we have telemarketing. Telemarketing works very well, where people actually call you and say, you last donated blood, would you like to donate again? I wonder always, Bernard, what do we do with the database of the entire single users who are up, or maybe up to 75% of our 273,000 pints or units a year? Do we have that database? Do we know them? Do we have their number? Do they have their email? Where are they? Because with that data, we can then reach them through multiple channels, either through social media, telemarketing, text messaging, even just calling and saying, we are going to have people who are going to call you and say, thank you for donating blood on this day at this hospital. And please remember that donating another unit, you can go to this place or you can call us. What do we do with that data? So I want to say that communication, Bernard, has to be personalized, has to be relevant, has to be real, has to resonate, and has to go beyond sending messages to the recipient, understanding their role.
All right, I agree with you on that, that it must be strategic. It must also look at the cultural nuances of the target population. It must understand that people have their own fears. There is donation, whether organ or blood donation is concerned, is voluntary and non-remunerated. That people must be willing to wake up without being coerced or without being asked to do so. They must be willing to wake up and go and donate blood or donate organs. The last of your 3 C's is about, community alliances, building these alliances. For a very long time, this conversation seems to have been domiciled exclusively at KNB TTS. It does not happen outside any other of these, whether government organs or private organs. It is their animal, it is their beast to wrestle with. What do we need to do as a nation to move this conversation away from the offices of the organization to the communities? Policies that we need to formulate. What are the new cultures that we need to develop as a nation and as a community to ensure that people see this as important? People put money in it, people put the right policies and infrastructures in it to move the conversation forward and at least turn this ship. Daktari, what do we need to do to build the right alliances for organ and blood donation?
Thanks, Bernard. That 3C of community alliances has to be driven by community alliances to achieve the first 2 C's. Has achieved that. These are alliances with the media. These are C must be driven to a regulated donation environment, safe for the donor and safe for the donee. So it is about achieving the multi-sectoral policy framework. So I would say what I've seen is that number 1 is private sector. That's a critical alliance because private sector alliance is right at the community. Everyone somewhere is near a private sector service delivery point, whether it's a pharmacy, whether it's a clinic, whatever it is. Now, so the private sector alliance is critical, but what is the regulatory framework that enables that? What's the policy and regulatory framework that enables that? So that, I think that's what I would like to say, that 3C must be done to enable the first 2 C's, Bernard.
Okay, asante sana. I should bring in a comment. I'm not sure whether Mr. Alex Mukwe from Kakamega is asking a question, but he's talking about community alliances. And in schools closed and blood was very expensive. In Kakamega, they got a partner who, in a way, had political interests. After your blood will be used for rituals. that they, even though they were lining up to donate and they were really chasing this conversation and changing the cultural perspectives on donation, a political competitor came on board and hijacked the conversation and said, your blood will be used for rituals. And as a result of that, the whole effort came down and the partner pulled out. Thanks, Alex, from Kakamega, for that comment. Daktari, what do you think of that? Even as we build these alliances, and we know for sure that this is a political nation, we are political animals. How do we safeguard this, and what do we need to do to ensure that where we build these alliances, the conversation that is not hijacked by other people? We know for sure that there are people who are willing to do this, other than the cultural nuances that we've talked about, and the fears, the stigma, and all these that we have. There are also the other issues, the social, economic, and all that. When people hijack these conversations, what is lacking? And what do we need to do? For instance, did that partner need to pull out? Was there anything that they could have done differently in Kakamega to take the conversation forward?
Well, blood donation is a very sensitive matter. It's actually culturally sensitive, it's individually sensitive, and there are many fears that people have. Of course, the one you're raising is also available in the literature on blood donations on rituals, and it is also community-based, because there are communities that are more likely to understand the use of blood for rituals than others. Communities that have strong taboos, for example, will need purpose and relevant information to themselves to understand and overcome their fear, their cultural fear. So again, as we say, the communication has been targeted to the community based on social behavioral understanding of those communities, number one. Number two is that this communication has to be continuous. The reason this incident happened is because this was a new thing. There was just an activity. It was a campaign by a political person. But if it was common knowledge to everyone that blood is relevant, we donate it all the time, we've never had it used for rituals, it would have been less important, for that message would have been less received by that community. So it's about continuity, repeated, consistent. But finally, it's also something I forgot to mention here, is the fear of the results of blood screening. I know that in some studies it's been indicated that the fact that results, serostatus, results of blood that has been tested is going to be communication. So if I donate and they're going to give me my results, what do I do with them? So those fears have to be overcome, but it has to be a continuous process. Communication is over months and years. It's not weeks or days. So it has to be consistent, and that's the only way to overcome those fears. And it has to be contextual to every community, which is why I say it's not through billboards. It has
to stay online. We need to move to Angela Langat, who is the Deputy Director for HIV Investments at the National AIDS Control Council, to build on that. And she is talking about leveraging communities for a donation culture. I should also say, as she stands, that Calvin Oude from Homa Bay is worried that he says here that the age for qualification to donate seems to be locking out a lot of students who would ordinarily be qualified to donate. And is asking, for instance, he's saying now in Homa Bay, they are finding it very hard to find a Form 1 who is qualified to donate blood. And the question for you, Angela, as you stand up to speak, is concerned. Is there anything we are doing about revising the age of donation, for instance? Should we revise it? Or are there other mechanisms that we can employ to ensure that we do not lock out key and crucial populations who are willing to donate? Karibu sana.
Calls observed. Thank you for the invitation to participate as a panelist of this very important conference. Actually, I think it's what NAC, the National AIDS Control Council, can share about community mobilization. What have been some of the lessons that we've learned as we've been at this for many years? As I begin, I would like to reiterate on NAC's mandate. We provide leadership for the HIV response in Kenya. Coordination of stakeholders, amongst many other things, on our mandates, and of course, dialogue is key. Over the years, we've witnessed a decline in the new HIV infections, and this is due to the central place of community engagement. I'd like to speak about a current model that we've been using to do our programming for HIV prevention. We've been coordinating the implementation of local innovation skilled through enterprise networks, which we call LISTEN, in Kiambu and Homa Bay counties. For this engagement to happen, as foundation, the Center for Global Health, Practice and Impact, Georgetown University, and CDC and KEMRI. The model actually uses a human-centered design, as Dr. Githinji has said, alluded to earlier, and places the communities at the center of scaling up the HIV prevention using existing structures in the communities. In Homa Bay, for example, we've leveraged on the networks of fisherfolk and the border riders. The LISTEN model calls for the organization of these existing networks into a community of practice. As is within the mandate of NAC, we build their capacity and they increased condom distribution, increased testing, increased circumcision among men, enrollment into the NHIF program. Other non-health achievements have included sensitization on road safety, increased licensing through NTSA, linking to microfinance and insurance companies, and sensitization on alcohol, drugs, and substance abuse. NAC has dedicated resources for the scaling up of such communities across the country, and of course we work together with counties to ensure that they also support them. Those are just my remarks. Thank you.
A brief but very thought-provoking remarks. You talk of the role of community mobilizers, or if we might as well call them, the role of community champions in this, as far as NAC is concerned. And we must all agree that the model of having community champions lead the conversation in their settings is very, very important, because people like to, they trust people that they know. Communication happens more effectively, behavior change happens more effectively as well when the people that being differently develop new cultures is somebody you understand, somebody you know, somebody you see every day, and therefore somebody whose message is you trust. So Angela, let me ask, and the audience, please, if you have questions as well, please ask. What can we do? What model can we, to use a horrible expression, what model can we steal from NAC and apply here as far as developing community champions for blood and organ donation is concerned? Do we need to go to the communities and establish? The Ministry of Health, for instance, uses CHVs to deal with some of the health challenges that might not be dealt with at the institutional level. Do we need to move there? Do we need to develop a champion culture at the village level, at the community level, so that we start migrating people away from the blockades of their cultures?
As I was explaining, the types, that's the border riders and the fisher folk. So once they are organized around that, what we do is build technical capacity for them to organize themselves in the same way to a trauma. So that's how it works. We've gone to those communities and we've used what Dr. Githinji alluded earlier to, the human-centered design. And basically that is placing the person at the center of designing a solution.
Any questions from the audience? Anyone with a burning? Yes, there's a lady there. Please give the lady there a microphone. Please introduce yourself and tell us what you do, and then ask the question.
All right, thank you. To be here, I'm more inclined to the organ part compared to the blood part. So you've mentioned that there are children in high school who are being capped out from donating blood. So I want to know, as we consider donation from high school children, are we factoring in the issue of consent? Are they told about it? Are they given information that they're able to rely on to give consent for them to donate blood? And the other question is, as we speak about communication when it comes to blood donation, how can we use communication to then convince people communication to organ donation? Thank you.
Asante sana for your question. Dr. Githinji, that sounds like it's your question. The issue of consent, especially for minors, and also communicating organ donation. Away from blood now, communicating organ donation. Mind taking that? Dr. Githinji?
Yes, thank you very much.
Okay.
The issue of consent is a really critical one. And I think it's not only for this. We are having the same challenge when we come to COVID vaccination, for example, where the science regulatory environment allows for vaccination for children below 18, now going up to 12 years, but the consent environment is very difficult to implement. So I think that's a critical question. I don't think I have a policy answer. I would just have a human-centered answer that consent is critical. It's important for us to be considered in the policy framework, and that when I was in high school, I think I don't remember being sent home, for example, to ask my parents whether I should donate blood or not. Of course, we relied on the health workers that came to us, and I don't even know what the practice is currently. I would say that the consent needs to be thought about, and the consent mechanism should be something that is integrated into an existing service. Integrated, for example, in the school enrollment. If you're going to go to schools, it should be integrated so that it's not every time they now run and ask. It should be integrated, but that needs a policy framework. I think that's what I would say, Bernard, but I'm sure there are people in the room who probably have a more robust answer than I.
Asante sana. Is there anyone who has a different take on the same? People in the room who would like to talk about consent? Yeah, the gentleman there, yes. Please introduce yourself.
The issue of consent was addressed in the standards. Yes, we had government. We had Ministry of Health has that extent to which they could donate to as parents. Previously, that's what used to happen. Right now, it is captured in the standards, so there is no problem there. Once we read the standards, we'll understand how this one works. Secondly, there was this question about students who are below the age. We cannot, from a certain age to a certain age. There are reasons, health reasons for that. So in this case, we recruit them. Please, recruit, even if it is a 1-day-old child, recruit. Then you will be doing zero work. You cannot just go to a who has never had something of that sort and then try to convince him to donate blood. It will be very hard. So it is good for them to come. You educate them about blood donor services, recruit them, and then wait until when they are at that age. That's when you can now allow them to donate. Thank you.
Asante sana, asante sana. There's a lady over there. As we move to the next panelist, please again introduce yourself and then either ask a question or make a comment.
Okay, thank you so much. My name is Gijoannes. I'm a lab technologist at Mpisha Hospital. About the consent for students in high school, I was just thinking, even as we think about the whole issue, there are times the children go for holiday, and if I like what Dr. Githinji said about if it can be introduced at the admission level, that the parents can be allowed to sign in for their children, so that when they get to that age when they can donate, they can be able to donate. Or the other thing could be is they can be given letters. When they're going home, they're given newsletters. So a letter for consent can be attached to the letter of the newsletter so that the parents can be asked to read it and consent for the child. And the other thing is I like what he's saying about education, awareness. We perish because we do not know. So if this awareness can be made in our schools so that the Kenya National Blood Transfusion Plus, the whole health sector, takes it up and we get to schools and do awareness to the teachers and even to the students. It's going to be a big deal. Take advantage of parent days, parent sessions in schools. Educate the parents, educate the students, educate the teachers as well, so that we demystify blood donation.
Asante sana. We perish because we do not know. That's what she says. And what other better way to introduce the next panelist? Hello. On that very, very powerful note. Mr. Ogola is a digital humanitarian. Please don't ask me what that means, but he is a digital humanitarian. And he is going to talk to us today about the power of social media in mobilizing and educating donors. We perish because we do not know. Can digital save us? Ogola, please.
So good morning. I think just before I talk about digital humanitarian, I just wanted to correct something. I've been on the front line for the last 12 years. I've seen death. I've seen lives being saved. We've told stories of hope. And it pains me that as a country, the people who donate blood are school children. We as adults don't have that donation culture. So before we even have this conference here, how many of us here know our blood groups? How many of us have donated? As a man, you can donate 4 times. As a woman, you can donate 3 times a year. I mean, every 3 months, a man every 4 months. So my name is Philip Ogola. I'm the digital humanitarian. Digital humanitarian is it's a calling. It's something which I taught myself. I'm someone who has no formal education. I'm dyslexic, and my dyslexia has made me do social good and use the digital space to change conversations, to champion campaigns. I've worked for the Red Cross, I've worked for the UN, I've served government agencies in various capacities. I've been on the front line in emergency responses, terrorist attacks, road accidents, building collapse. I've seen the blood need in the country. And the best conversation we can have is among ourselves. And social media has become our lifestyle. Social media has become a day-to-day activity which every one of us has a phone, and each one of us right now is probably tweeting or WhatsApping. But do we use it to actually amplify conversations? Do we use it to actually mobilize and even tell stories? So as digital humanitarian, I've supported the Kenya National Blood Transfusion Service in terms of digitizing their communication, assisted them in terms of training, raising awareness on social media. And this is the power of social media. Through social media right now, the country can actually mobilize for blood. Through social media right now, patients and relatives can actually post on social media, on WhatsApp platforms for blood. And as a country, and this is something which we also need to have, we don't have a disaster response mechanism, especially on the digital front, where all these donations can be siphoned, can be funneled to one sphere. So the best way to actually mobilize blood on social media is just to tell our stories. Blood donation cannot be done by KNBTS alone. Blood donation cannot be done by Ministry of Health alone. It's a collaborative effort. We have to jointly push this conversation. Let's say, for example, the corporates can actually have a donation cycle, and this is something we've evidenced, where corporates actually have CSRs where they keep donating blood. We also need to have like a donation culture in our schools, in our universities. And the best storytellers are actually patients. The best storytellers are actually relatives. Social media is about emotions. Social media is about relatability. So the more we tell our stories, because what we have right now as a country is knee-jerk, where we post blood appeals based on my mom is sick, my brother is sick, my relative is sick. Then after that, all goes quiet. Nobody bothers if the National Blood Bank has blood. Nobody bothers to ensure that we have our labs are actually kitted. And during the COVID pandemic, I was part of the digital task force for the MOH. And that time, if we had a terrorist attack, our blood banks were actually dry. So I want to challenge you once again. How many of us donate blood? Social media is a very powerful tool. It's a powerful tool because we've done campaigns with KNBTS where we actually organized a blood drive through social media. We didn't send an invite to the minister, we didn't send the invite to the CSS, but they all came because it was viral on social media. So I want to tell you once again that we're not tapping the digital space to not only tell our stories. We're not tapping the digital space to collaborate and support social media, where we use it to actually, patients can actually, like if today I donate my blood to my panelist here or Dr. Gidinji, and then Dr. Gidinji tweets and says, thank you, Digital Humanitarian, for donating blood. That is how people start getting to understand that they need to actually donate. But as it is right now, we don't tell stories on social media. We're only telling stories on one end. So my appeal right now is just to say that social media can actually be, it has saved lives. We've seen lives being saved. And I have so many, I had a whole presentation to do, but the time was short. Kisumu. And this is how collaboration works. At times you get a blood drive in Turkana and that blood is in Nairobi. How does it get to Turkana? These flight operators, Kena 540, and they actually come on board and actually offer to fly that blood. So it shows that if we all collaborate, if we all come together and actually support the Kenya National Blood Transfusion Service, we can have blood banks and we can tell our stories. And social media conversations are being dictated by the youth. We are old here. We are the older generation. But the youth are the ones who dictate conversation on social media. So it's high time we also engage them. They get to understand why we need to have a preparedness plan as a country. And one of the preparedness plan is just to ensure our blood banks are kitted. In case of an accident, in case of a terrorist attack, in case of a pandemic, it's actually having the blood banks being full. So I just wanted to tell you guys that social media has made me see the flip side of life. Social media has made me see how lives can be saved, and the best way to actually use social media is just to tell our stories and to inspire others. Thanks, guys.
Asante sana Ogola for that. He's talking about the power of social media and the power of storytelling, especially personal, emotional storytelling. What are the things that we need to do? What do we need to develop? What cultures, tabias do we need to develop to harness the digital space? Almost everyone, I would bet, in this room today has a social media account. I was just looking at, the digital space in Kenya relative to the population. At the start of the year, we were at about 55 million Kenyans. And out of those, 23.35 were on the internet. 23.35 million Kenyans were on the internet at the start of the year. 11.7 million of those were on social media. Facebook, Twitter, Instagram, TikTok, and all those other social media platforms. How are we harnessing that space? What stories are we putting there? I follow a lot of corporate social media accounts, and what they do is to post, to tweet about what they are doing at the policy level. We are formulating this. We are meeting in Naivasha about that. The CEO is doing this. But rarely are the stories of the communities they target posted there. How many of us, for instance, at the corporate level, are on TikTok if we want to target the young people? And what types of stories are we posting there? Do we need to be there? Can the Damu drive go there so that we educate people on what they need to do using the platforms that they consume? If we are on Twitter, then what kind of messages, what kind of stories can we put there? Can we do Instagram stories about blood and organ donation so that we target the key populations that ordinarily wouldn't be reading our billboards and our booklets and newsletters and all that? Ogola says that there is power in storytelling, and social media gives us the platforms that have the right reach for the audiences that we are targeting. So, Ogola, let me ask you this then in relation to that. What do, away from the communities, let's now talk about the corporates. What do the corporates need to do now to change the narrative and how they have been using social media? Do they need training on social media use? Do they need training on storytelling on these platforms? They need to be short, pithy, but very, very effective stories. How do we harness the power of social media for social good?
That's a very good question. I think first of all, corporates need to sponsor digital literacy across all schools. The more the generation understand how to use social media, because there's the good side about it is it's a storytelling arm. But on the flip side, there are unethical practices. Let's say, for example, there's an accident, people have died, and people taking photos and sharing online. So I think there need to be digital literacy where corporates can actually sponsor boot camps, mentorships for the youth. But in terms of using social media for good, I can say that corporates do CSR, but how many corporates support awareness around organ donation? And organ donation is something which is very close to my heart. I have keratoconus. It's an eye condition. And there's a day I had to go for surgery, so I had to wait for a donor to actually donate an eye. So it will be key that we also change our mindset around organ donation. And this is something which can be, I don't like talking about my life, because when you are near death, and then you have to depend on someone to donate an organ for you, it hits home. And some of these stories we don't tell them. So for me, I'm looking at corporates becoming more human, as in COVID pandemic has left a trail of trauma. If we can now raise awareness on how we can use social media for good, where every corporate can actually ensure every month there's CSR, every month there's activity actually supporting the likes of blood banks, the likes of the spinal unit. And it doesn't cost much just to retweet or to reshare posts from the blood bank, because today it will be you, tomorrow it will be someone else. So corporates play a big role. Even like we can have like a weekly, monthly days where people can actually donate blood. And as a country, again, I'll keep repeating this. We do not have a disaster response mechanism. Something happens, that's now when we start donating blood. Let's look at preparedness plan, where we're actually looking ahead. And that's where corporates can actually play. That's where organizations can actually play and ensure that we're using a platform where people can actually have and share conversations. And also it's very, very key, Bernard, to have the digital literacy where patients who are telling their story are not stigmatized. People who are actually telling their story are not sharing, because you see, blood donation also has a lot of privacy and confidentiality of the patients. So it will also be key to raise awareness on ethical practices, especially when you're actually posting online. Thanks.
Asante sana, Ogola. Dr. Githinji, I know that you needed to log off. Are you still there? And do we need to release you? Please unmute, Doc.
Yes. I would say that I've enjoyed the conversation, but I have one final remark before I leave, is that issue of convenience. Even now, and I have heard Ogola very clearly, if I was to post on social media and say, please donate blood, and somebody asks me, where do I go? What is the answer to that question? So I think the infrastructure of the alliances, private sector alliances, with the public sector, need to go beyond the outreaches. Because this is where the fear is. Recently I had someone reach out to me and say, we really need blood for a relative. And how do we get it? And I didn't know, I know, of course, I know Ndugo Kilonzo, the CEO. Do I go to the CEO and say, my friend's relative needs blood? I mean, no, of course not. The question is, what is the process? What is the process of ensuring that blood is available to them? And what I did is that I referred them to the Damu-Ke Google app and say, please record your need here. Somebody may actually help you. And they came back and said, yeah, they got help. But the convenience, even the communication must be matched with convenience. And that's what we are seeing with the COVID vaccine as well. If you tell people, get vaccinated, then they are at work. Do they have to go and find a clinic somewhere and queue for 3 hours to get a COVID vaccine? Or are they able to say, I intend to get vaccinated, and the vaccine is available when they need? The blood should be considered the same human-centered approach. If I post today and I say, please donate blood and let me know who donated blood by tomorrow so that we celebrate you, then the number of questions I'll get is, where do I go? What time? How do I do it? So this thing that Ogola is talking about is critical. At the same time, the infrastructure, the convenient infrastructure, must be part of its success. Thank you very much for the time. I'll log off shortly. And thank you, Bernard, for moderating this fantastic panel.
Asante sana, Daktari, for being with us this morning. Tunashukuru sana. A round of applause for Daktari as he logs off. But we still continue with this conversation. He brings, and he's been talking about this all morning, communication and convenience. It appears that the model we are using is not sustainable. The drives, the blood drives that we keep having every now and then are not sustainable because they are not developing the culture of, donation that ordinarily would drive this. We need people to be aware of it and to voluntarily, without being asked, without being coerced, without there being a drive. We need people to be, would anyone today wake up in the morning and say, I am going to donate blood if there is no drive? And if so, where do they need to go? Where do they need to go? If you want to buy airtime, you buy it at convenience, either on your mobile phone or at the nearest kiosk. So when you're donating blood, what do you need to do? What are the convenience infrastructural things that are available to you so that you do not have to walk long distances, spend a lot of money, spend a lot of time, be inconvenienced because you want to donate blood? Ogola said before he sat down that he doesn't like sharing his stories. He doesn't like getting personal with his stories. But we are lucky. We have someone in the room who doesn't mind sharing her stories. And her name is Miss Leah Kilenga, who is the founder and CEO of Africa Sickle Cell Organization and a person living with sickle cell. She's going to talk to us about leveraging communities of blood recipients for sustainable donation. Ogola also talked about, he said, you don't know what happens to you, the thoughts that cross your mind when you are in that situation, you need help. Your life depends on somebody else. You're seeking a donor, and you don't know whether you're going to get that donor. Leah has been through that, lived it, lives through it every day, and she's here to give us a few thoughts about what we need to do from our experience and the experiences of running the organization. Karibu sana, Leah.
Hamjambo nyote. As our very enthusiastic Bernard said, my name is Leah. I am a sickle cell warrior, and that is the first priority of my life as a patient. And the second priority is to lead an organization that improves access to sickle cell care in rural, resource-poor communities, Africa Sickle Cell Organization. So on a good day, a day that I have received blood transfusion, my hemoglobin levels are 8. On a really, really bad day when I need to go to the emergency room for admission, my blood levels are at 3. And on a day like today, where I have not received blood transfusion for almost 3 years now, but I'm still working aggressively stressed with life, my blood levels currently are 5. Okay? I'm operating on the HB of 5. So I was born in a family where 3 of the 4 children have sickle cell. So transfusion therapy was a way of life, and the people around us, our families, our neighbors, were donors by default because of the need we had in our household. Today I'm talking about leveraging communities of blood recipients, specifically the sickle cell community, one of the, I think, underserved communities, one of those communities majority of you or a few of you may not know about, that we really depend on transfusion therapy for our livelihoods, for the health of our lives, for the management of sickle cell. Okay. Disorder that changes the normal round red blood cells to sickle-shaped cells. So these cells are sticky, they are rigid, they're inflexible, and they are fragile. Okay? So they break a lot, and their lifespan is between 10 to 20 days. For me, my red blood cells last for 10 to 20 days, while yours lasts for 120 days. So unaona hiyo shida? Yeah? So aside from that inconvenience, they carry lower hemoglobin and lower oxygen, causing symptoms of intractable pain, acute chronic pain, and also chronic anemia. Okay? Next slide. So the complications of sickle cell, based on what we have discussed about the red blood cell, these are the multiple complications that we live with day by day. Some of us live with multiple, maybe 3 or 4 of them. Others live with more than even 5 of them. So with our blood being affected, our red blood cells being affected, we are susceptible to multi-organ, multi-system, whole body complications throughout our lives. Pulmonary complications, cardiac complications, renal complications, hepatobiliary complications, all those complications that we see. Okay? However, so for management of sickle cell, we have a number of things that we usually do. We have penicillin for children, folic acid to create new red blood cells, malaria and infection prophylaxis. We have hydroxyurea now that is available in Kenya, thanks to the government and the policymakers and a few decision makers in this room. And one of the critical therapies that we need is blood transfusion therapy. And now, due to advancement in research, bone marrow transplant therapy and gene therapy to help cure the disease. Unfortunately, most of the people in Kenya still lack access to these therapies that I have mentioned, okay? Because of the policies that we have in Kenya, there's access to hydroxyurea. However, in rural, resource-poor communities, we still do not have penetration of these services. However, those who have sickle cell present in the hospitals with chronic anemia. So the almost always management that they are given is blood transfusion. Next slide. So for Kenya, we are currently, it is estimated that 14,000 children are born annually with sickle cell. But without treatment, without intervention, up to 90% die before the age of 5. This inequality is exacerbated because of the centralized care we have in Kenya. Most of the care for sickle cell is only available in urban centers and private health facilities. So places like Nairobi, Mombasa, Kisumu, Eldoret, areas without access to sickle cell, we see people travel long distances to access this care and pay private hospitalization to access this care. With regards to the economic burden, sickle cell, it is estimated that these 14,000 newborns cost the country 1.6 billion Kenya shillings. approximately 0.02% of the GDP spent on prescriptions and medications, but this can be avoided through timely screening and linkage to care. And lastly, mahali mimi natoka kule pwani, tuna unyanyapaa. Mnaelewa? Sasa tunapelekwa kwa madaktari wa kitamaduni, wa kimila, kutuchanja, kutusafisha, kwa sababu ugonjwa wa sickle cell unaonekana kuwa ni ugonjwa wa kurogwa. Mmeelewa? Sasa lazima tupelekwe, tuchanje, tutakaswe kwamba hii shida kuna jini gani kule kwa ile familia kina fulani wanafuga, hawa watoto hawakui, hawa watoto wanakunywa damu kila siku. Hivyo ndo watu wanafikiria. Alafu sasa kuna the expenditure, ile gharama. Mtu wa kusafiri mpaka Nairobi, mtu kukaa na mtoto, mtu kuenda kwa vipimo na dawa na shindano za kila mara, zinatoa manunguniko sana kwa moyo wa wazazi. Sasa hii shida inaumiza sana society na jamii. Okay? Na watu kama sisi, mimi nina miaka miwili zaidi ya ndugu yangu mdogo. Ndugu yangu mdogo katika familia yetu tuko 4. Watatu tuko na ugonjwa wa sickle cell, ule wa mwisho hana. Lakini yeye alimaliza shule mbele yangu. Kwa nini mimi sikuwa naenda shule mara kwa mara? Mimi nilikuwa mgonjwa, nilikuwa nasafiri, nilikuwa napelekwa kwa dawa na matibabu, yeye yuko shule. Si unaona hiyo shida? Next slide. Okay, so people living with sickle cell are families, people like myself, sickle cell warriors, caregivers, mothers, and communities with sickle cell. So we partnered with KNBTS since 2015. We started doing our blood drives at KenCom. I don't know if any of you remember. We used to have billboards of these photos up at KenCom. We're like, how do you save our lives? These are the people living with sickle cell. If you don't know what sickle cell is this disease. These are the people, they are found in these areas. Please come and donate blood. We used to solicit blood. On average, we used to raise 300 pints at every blood drive. Next slide. So, people living with sickle cell are found in 3 areas: the Nyanza area, the western area, and the coastal area. When Daktari was talking about convenience, we want to target areas of proximity of where these people are found. These are the areas where we can leverage communities of blood recipients to ensure that there's availability of blood and blood components at these particular areas. We work in the coastal region, but I know a few partners who work with these other regions that ensure there's blood availability. Next slide. So why leverage sickle cell communities? Because we have a recurrent need and we require these therapies every single time. So now, because sickle cell requires most of the complications and most of the symptoms of sickle cell can be managed by blood transfusion, this is something that's almost always prescribed when we are hospitalized. The ensure sustainability at all levels. So for Taita Taveta, where we work, we ensure that because we don't want people to travel to Nairobi or to travel to the cities, we mobilize communities of sickle cell warriors to be able to create demand for blood components, blood services, blood components. So without this demand, then the government and the community are not able to relate why do we need to always ensure there's a consistent plan to ensure blood donations. Humanize the process. A lot of people, when you go and ask them for blood, if it is not a relative, if it is not a close family member, if it is not a neighbor, then it does not connect to them. So when you build trust with the community, when you live in this community and these people know you that you live with this problem, they are more willing to donate and to ensure a culture of donation because they understand, oh, hile shida kule kumbe si kurogwa. These are people who need this blood, and I can be able to support them by providing this blood. And lastly, education and awareness. How do we educate the community there? Why is it important for them to donate, to have this culture of donation? Why is it important for them to provide blood for these particular disease conditions that are present within those communities? And how are we be able to remove the stigma around blood donation when we ensure that blood donations relate to saving lives instead of the negative stigma that come about with blood donations from communities that have high superstition rates. Next slide. Next. So for sickle cell, when we do blood drives, we ensure that we have screening and linkage to care. This is important because this is a way to capture the community members to understand the burden of sickle cell within communities and also be able to align these numbers to the availability of services within these communities. So lastly, how do we leverage communities like the ones that I come from, communities of people living with sickle cell of blood recipients? Mobilize and empower sickle cell communities. You identify where they are, you recruit them, you inform them and skill them to be able to tell their stories, to be able to go for donor recruitment, to be able to relate their condition with the need of blood and communicate this to the community. We need to establish local strategic partnerships, those with the least amount of agency in communities. People who live with these conditions, patients especially, need to partner with people with the greatest amount of agencies. So one of our big partners is the Office of the First Lady. The Office of the First Lady is very close-knit within the community, is very well trusted, especially within patients. So what we do is use their networks and be able to bring in stakeholders like the Red Cross, the Rotary Club. We used to bring in regional blood transfusion services and the level 3 and level 4 hospital to be able to coordinate a well-organized blood drive. Because once we do not have the capacity to plan blood drives, but they are able to plan blood drives, and we are able to leverage our stories during these campaigns. Our planning and resource provision. So where the areas that we work when we ensure that every sub-county at least we plan 3 blood drives per year. This makes it easier because we create a culture of donation, because people know that every 4 months these people will be here. We know that these partners every 4 months they need to contribute for this particular campaign. We understand that the Office of the First Lady need to mobilize resources every 4 months, so everyone is in tandem and is in line, and we do not have scarcity of blood and blood components. Lastly, integration of activities. So aside from those planned activities, the other thing is we leverage disease days, World Cancer Days, Sickle Cell Days, Hemophilia Days, those days that we have a patient community that is there physically to show the need of blood. We leverage the blood campaign, blood donation camps to be able to integrate with these medical camps that have been organized with the community, so that people can also connect and relate the need of why blood donations are important. Lastly, next slide. I encourage you all to give often, to give freely, especially to people like us who need blood the entire of our lives. And yeah, thank you very much.
Asante sana Lea. Lea anasema huko kwao kuna unyanyapaa. And I've seen people clapping for unyanyapaa, others laughing about unyanyapaa and all that. What does unyanyapaa mean, Lea, so that these people don't end up clapping for the wrong things? Stigma. She says unyanyapaa is stigma. So those of you who clapped for unyanyapaa, please apologize after this. But we are drawing towards the close of this first session on this morning, and I just need to reiterate, for those of us, for those joining us online, please, if you have any question and comment, type it on the chat. We'll relay it to the panelists or to the audience. Leah talks about mobilizing and empowering communities. And there is a theme, a thread of a theme, mobilizing or even in communicating. That the way we design our models, the processes that we put in place must be strategic. They should not be knee-jerk. She talked about the blood donation drives that have been having, but those are not sustainable in the long run because they are not developing that culture of donation. They just happen when there is a need. There's a drive, we need to collect these many liters of blood, then we go for it. But is that sustainable in the long run? Community mobilization, are we strategic as well in that space? How are we addressing the culture concerns and the other inhibitions, whether social, whether health, whether aid, so that we get more? Has been said here early in the morning that a lot of this, but should that be, but away from the schools, what do we need that Dr. Githinji and Leah have been talking about? But Leah, you also talk about humanizing the process. And I think that's, to me, blood donation, organ donation is still an norms that we are developing. And they are there, but they are not human enough. The people who go to donate, don't rescue them. What do we need to do, from your experience, when you're doing these drives, what do we need to do to humanize this process? Is it an education thing? Do we need to change the cultural perspectives? Do we need to have drives that are not about donating, but about educating people about the culture of blood and organ donation? And from your point of view, do you think that you're making any progress as far as humanizing? This is normal. This is not organ and blood donation as something.
And every year for different sub-counties, we use what we call community barazas. Community barazas allow now the patients and people like us to speak to the community of what we are planning, to tell the stories of what sickle cell is, to tell the stories of why sickle cell and why blood donation will impact the lives of people living with sickle cell. And with regards to that, people are able to understand that we are the community members benefiting from these services, and the blood is not going to ghosts or rituals as people think, but blood is going to specific individuals who actually critically need this blood within the communities. So for us, we really speak to the grassroots systems that are in place, the community barazas, the churches, where we're in close proximity with. So success rate, yes, we are very successful with our blood drives. We have a very good turnout, and I think we're doing well every time we go with regards to educating the community about blood and blood components and establishing that culture.
Asante sana Leah for that. We need to draw this to a close. Just to remind you, this session has been discussing the issue of mobilizing the public and building alliances for sustainable blood and organ donations in Kenya. Our keynote speaker at the start of the session was Dr. Githinji Gitai from AMREF, who has since logged off, who has just finished making a presentation, who is the founder and CEO of this Africa Sickle Cell Organization, and also a person living with sickle cell, and Mr. Philip Ogola, who describes himself as a digital humanitarian. My name is Bernard Mwinzi. As I said earlier, I'm managing editor of the Daily Nation at the Nation Media Group, and also the health and science editor at the Nation. As we close, I would like to call Honorable Professor Justus Inonda Mwanje to come and panel. Professor Justus. So Professor Justus is the CEC Health Services at Vihiga County. Karibu sana.
Hey, DJ, fast. Can we appreciate the panel, please? Thank you so much. Thank you for a great presentation. I think we've learned a lot about the importance of building alliances, the importance of using digital media. Thank you for sharing your story. Yeah, I really, really appreciate your story. And thank you for being with us as well. They will remember as they go back to their offices. So, asante sana, you really appreciate it. So I want to call Peter Waiganjo to please come and take Dr. Gita his gift. He's online, but we also want him to know that we were thinking about him. Peter Waiganjo, please come. And by the way, I'm very excited because Professor is my CEC back at home, so it's good to see you. Yeah, there's a photo being taken. Yeah, so please make sure Dr. Gidinji knows that we were thinking about him and we really appreciated his presentation. Asante sana, yes. Let's appreciate him for doing a good work. Okay, so who is here? Leah, come. That's a real champion, right? She was speaking those numbers. You are. Angela, for representing Ruth. Thank you so much. We are really grateful. Yes. Yeah, bring the bag. So, the next one is my dear friend and close associate, Philip Ogola. Philip, we need a nice shot. Yeah, we need a nice shot. Thank you for sharing your ideas on how we can spread the word and how we can leverage the power of social media. Thank you very much. Yeah. So then our moderator, we haven't forgotten you. So moderator, kuja pia tukukumbuke, sindio? Thank you for doing a good job, and especially let's appreciate him for ending on time. I had really asked him to please make it on time because we have a short day. Thank you so much for making it on time and making sure we finish this session on time. Thank you so much. Yeah, so thank you, Prof. Thank you, Amelia. We need to talk about what's happening at home. I'll catch up with you later. Now is the moment for the breakouts, and I want you to listen to me carefully. Breakout C on lessons learned from advocacy and campaigns, you remain in this room. Breakout C. The rest of the breakouts, you're doing the long walk to freedom. So major now. So when you get to the reception, you will choose the room that you want to go to. But listen to me very carefully, and especially for those who will be moderating the sessions. We are expecting a high-level guest to come and close this event. So the people must be back here by 12:30. By 12:30, which means that at 12:15, you have to wind up your session. So at 12:15, I'll have somebody coming round just to remind you that you have to have closed your session to allow people 10 minutes to walk to this place. So today, you will pick your tea from here. All the teas are being picked from here. Pick your tea from here and then walk quickly to your session so that we can start. Right now, it's 10:26. We're going to give you about 20 minutes to pick your tea. At 10:45, the sessions in the rooms are going to start. They're going to start at 10:45 and they're going to end at 12:15 on the dot. All right? So thank you so much. Please make sure you come back for the closing ceremony. The band that was here on the first day is going to be here to entertain us. And I want to promise you that the guest who is coming is going to be a very good surprise. So enjoy the sessions. And please, listen to me carefully. Do not leave your laptop or any personal belongings on the chair. There are some people who come to shop at these events. Take care of your personal belongings and carry them along with you so that you do not be separated from them. Please carry all your belongings. Some people have lost laptops here. Some people have lost phones here.